Today I'm going to present a research study done on Milieu teaching called The Language Delay and Effect of Milieu Teaching on Children Born to Cocaine Exposed, a pilot study. So the goals of the current study were to implement a language intervention that would enhance the impoverished environment that's typical of children who are prenatally exposed to cocaine and other drugs. The authors also wanted to implement and examine the effectiveness of Milieu teaching specifically on expressive language ability. They also wanted to enhance the literature on substance exposure and intervention and provide an example of how a carefully chosen intervention strategy can improve developmental outcomes for early identifiable risk groups. So the research questions that are attempted to be answered in this study are: will children enrolled in the Linda Ray Intervention Project improve expressive language abilities through the use of the MT paradigm? Will spontaneous words increase? And also, will multi-word utterances increase? So just a little bit of background on the Linda Ray Intervention Project. This is not the actual intervention that the study is examining, but this is the program that the children were enrolled in who are the participants in the study. So essentially, it's a large-scale intervention research project. It's designed to examine the effect of an educational intervention on cognitive, language, and behavioral outcomes of children that are prenatally exposed to cocaine. The intervention services are child-centered, and this is due to the possible caregiver changes that we commonly see with drug abuse. The children are transported each morning to the center. They're provided early intervention services pretty intensively for 5 hours a day, 5 days a week. And efficacy for the LRIP is found in research, and specifically it's been shown to improve developmental outcomes in cocaine-exposed children. So why MT? The authors chose Milieu teaching as their specific strategy to examine in this study because the research has suggested that children prenatally exposed to substances may be at risk for arousal modulation and attentional deficits. It has been found that the didactic and direct teaching techniques can be overwhelming and ineffective for this population. So as we know, as we've learned previously in the course, MT merges incidental teaching, manned model procedures, and time delay into a naturalistic and socially interactive play session. So it's more appropriate for this population. The literature that does exist on the efficacy of MT in high-risk populations primarily focuses on the effectiveness of teaching the MT strategies to the caregivers and thus its subsequent impact on language. The participants in this study were between 18 and 20 months old. They were identified with a language delay through assessment of the CDI and the REAL, and they all scored below the 20th percentile on both assessments and more than one standard deviation below the mean on the REAL. So like I said, there were 4 children, 3 African American boys, and 1 biracial female. So the authors did a baseline collection of data through the aforementioned standardized assessments, and they videotaped 20-minute play sessions. They had 3 baseline interactions that were conducted every 7 to 10 days for each child. And each baseline interaction was coded for the number of spontaneous words produced as well as the number of multi-word utterances produced. And as you can imagine, there were some variations in the length of interactions between children, and the authors controlled for this by averaging the utterances over 15 minutes. As far as the intervention sessions, they were 16 weeks of individual MT sessions. Each child had a primary and a secondary interventionist. The children were removed from the center-based classroom and they were taken into a quiet room with less distractions. The primary interventionist would implement all MT sessions 3 times weekly for the first 4 weeks, and the following 12 weeks, the primary and the secondary interventionists facilitated the sessions twice weekly for 4 sessions a week. And the study mentioned that there was no specific absentee data collected, but that no children were notably absent throughout the study. And this is probably due to the fact that transportation is provided for the children to and from the center every day. So this is just a sample of an intervention schedule that the authors included in the study. The MT sessions, so as we've previously talked about in the course, the environment was arranged to promote nonverbal and verbal requests. The interventionist followed a series of specific prompts, including models, MANs, and time delay procedures. They had a motivating play routine that was established by the interventionist, and it involved turn-taking sequences and focusing on a single object like a ball or an event like peekaboo. And once it was established, the interventionist withheld the object or event to interrupt the routine, and if the child failed to respond either verbally or non-verbally, the interventionist produced a MAN, such as, "What do you want?" If the child then produced the correct use of a desired vocalization, the interventionist provided positive verbal acknowledgement, expansion of the target behavior, and granted access to the requested object or event. And if the desired vocalization was not produced, the interventionist produced the target word and phrase as a model for the child. And the forms of communication increased in complexity throughout the session. The assessments for the intervention included videotaped assessments that were conducted at baseline, 8 weeks, and 16 weeks to measure progress. Consisted of 3 interactions. The primary interventionist, the secondary interventionist, and a general assessor all interacted with the child. So the general assessor was used to ensure that any progress in language development was not due to familiarity with the interventionist. And the individual who coded the video interactions was blind to the points and times in the assessment, so they didn't know if they were looking at week 8, week 16, or at baseline. And it was again coded for spontaneous word and multi-word productions. So here is a graphic representation of the results. There were actually some pretty impressive gains, and some of the gains were recorded in this chart and some of them were not. So for example, at baseline, as a group, they averaged about 1 word per 15-minute session and no multi-word utterances at all. In the first 12 weeks, the group averaged about 5 words per session, and you can see at 8 weeks, they had 10, 7, 12, and 9 respectively for an average of 9. After the full 6 weeks, the group averaged 17 words per session, which is obviously a huge gain. Individually, child D demonstrated the greatest gains, followed by C, A, and B respectively. And all 4 children showed improvement in multi-word utterances, which is probably the most promising finding. And this is an example, a graphic representation of their real scores pre and post intervention. And the test scores, as you can see, for all 4 children increased an average of 15.75 points from 18 to 24 months. And this gain is equivalent to a full standard deviation. So although it seems that the gains are impressive, there are a few points to consider with this study. There were some methodological limitations. For example, there is an extremely small sample size, so it's hard to generalize results from 4 children, as you can imagine. Also, the interventionists were all educated individuals with a background in child development. It's also important to consider whether the gains were due to the MT strategy alone, or if they were secondary to participation in an intensive intervention program such as the LRIP program, which has already been proven to improve developmental outcomes. Also, the children were not randomly selected, and the authors acknowledged that having no control group for comparison was the major limitation of the study. It's also of note that MT is a costly intervention, may not be cost-effective for many people, and the long-term impacts also need to be examined because, as we said, this is a pilot study. So that being said, the preliminary results from this pilot study suggest that MT may be an efficacious treatment strategy for children prenatally exposed to cocaine. However, future studies should substantiate this evidence by increasing sample size, randomly assigning participants to a treatment or control group, and examining the long-term effect of language gains. And these are 2 related studies that I cited earlier. Like I said, this is a pilot study, so this literature is more about training the parents and caregivers of the MT procedures. And that is it. Thank you.